Great. Thanks for being with me today to talk about Duopa a little bit.
You bet.
So maybe you could tell us a little about you.
So my name's Jason Aldred. I'm a neurologist, a physician. I'm board certified in neurology, and I'm fellowship trained in Parkinson's disease with a 2-year clinical research fellowship. And my practice is Northwest Neurological in Spokane, Washington. We are a Parkinson's focused practice. We have a very large DBS clinic. We've had over 500 DBS patients come to the clinic that we actively manage. And did one of the first DBS in Washington State in '97. So we have a lot of experience with very advanced people with Parkinson's, early in diagnosis, and as they progress through Parkinson's on into the advanced stages. So we're pretty comfortable with those types of problems.
Great. So you've been using Duopa now, where I don't know if you were part of the clinical trials, or so that's just another option for people with advanced Parkinson's?
Right. So I was not part of the clinical trials for Duopa, but when it became clinically available, I was very, very excited. I have prior research in levodopa infusions, which is done intravenously. Levodopa, as you know, is a very important medication for Parkinson's patients because it's very simple. It's turned into dopamine. Dopamine is one of the key neurotransmitters that's low in Parkinson's disease. Over time, as the disease progresses, wearing off of medication occurs. And with that, the wearing off effect, resuming Parkinson's symptoms with increase in tremor. Although not only that, but slow movement, stiffness, slow walking. And then when the medicine kicks in, the involuntary movement called dyskinesia, the involuntary wiggly movement can come back. And it's not always bothersome, but for many patients, it can be very bothersome or debilitating. And there's lots of options, fortunately, nowadays with Parkinson's disease to live well with it. Exercise is very important, rehab services, PT, OT, speech, medication, and surgery, typically. However, with Duopa, what we have is an advanced therapy option that is really a dramatic departure and a really new option for patients with Parkinson's disease. So after medications have been adjusted, one of the key things that we are able to do is to smooth out the response so that the medicine goes and kicks in and works, and then if it wears off, we can adjust that wearing off effect to minimize that so that there's less of that wearing off effect and more good normal movement during the day. Even with best medical management, the best doctors in the world, the most experienced, and no limitations to medications, even with that, patients with Parkinson's may still progress, and often do, to have very poor quality of life because of medication wearing off or the dyskinesia. And with Duopa, the really wonderful thing is being able to continuously stimulate the brain with dopamine, to deliver the chemical dopamine in a continuous way. Interestingly, we don't end up using a whole lot more levodopa in the formulation of Duopa, but it's the continuous delivery. So Duopa is carbidopa and levodopa, just as a typical patient with Parkinson's would take it orally, but instead it's delivered in a suspension and it's dissolved. So a lot of work has gone into making this medicine work well, come from a solution, and be very safe. And it's delivered via a cartridge and pump device with a tube that goes into the stomach, and then it passes through the stomach, past the stomach, to the next area, which is the small bowel area. And at that location, the Duopa gel, which is carbidopa levodopa, again, nothing new about this medication, the chemical, other than it's formulated now in a suspension. This is delivered continuously from the time you wake up and put the cartridge on the pump and turn it on, and continuously delivered until you go to sleep at night, are ready for bed, and will discontinue the pump. So it really is quite a remarkable reinvention of the wheel, you could say, because for all the novelty and newness here of this treatment, a lot of it's really pretty basic. It's still using the levodopa that everyone with Parkinson's already is on in one form or another. And using a tube delivery method that's really been around for a long time. We've been delivering medications and treatments via tubes into the stomach for a long time. One very important difference here is up until now, when you have a tube put into your stomach, it's been associated with dying or the end of life. And I think it's kind of scary for patients to think about having a tube go into their stomach and think that that's possibly it means that they're in an advanced end stage, or, they're going to die soon. But actually with my Duopa patients, we've had over 10 patients now go through and do great. We see that they're more active, more alert, more able to participate in their daily activities with improved quality of life. So it's very different. It's putting a tube into the stomach to deliver a treatment that actually is intended to be associated with doing better, not doing worse. And that's a bit to wrap your head around if you're a patient, I think, considering this treatment option. You really have to understand that the intention is that without the tube, without this delivery method improving your quality of life, you'd actually be worse than you would be with the tube. And often, people think that having something like this done means that that's it. There's nothing else for them, and that's just not true. One thing that's also really wonderful about this type of treatment is it's a very good way to simplify Parkinson's treatment. If the medication is not taken very close to an on-time schedule, there can be many consequences with either getting too much medicine or not getting enough medicine delivered reliably. And the reliability of having the medicine delivered through the tube, which actually delivers it past the stomach exactly to the point where it is intended to go, continuously, is a big thing. With Parkinson's disease, as it advances, the stomach may slow its movement. The stomach may hold on to the medication, the levodopa, but not deliver it past the stomach to the small bowel where the absorption occurs. And so the Duopa pump system, and it really is just that, it's a system. It's the gel treatment, it's the cartridge, the pump, and also the tube itself is part of the treatment. And the tube physically bypasses the stomach. It goes past the stomach to the small bowel. And that bypassing of the physical barrier of the stomach, getting the meds past the stomach is really one of the big breakthroughs with this type of delivery. And there's nothing else quite like this available to our patients in the U.S. This has been available in Europe and Israel for over a decade, and really been very safe and well received there also. So I really offer this for patients. My patients now, when I tell them about new diagnosis, I let them know that there's all these advanced treatment options. And then at the time of DBS referral, or when they're thinking about something like that, an advanced option, I think it's very appropriate to present them with Duopa or DBS as an option. And we don't have any real head-to-head studies that compare deep brain stimulation to Duopa. But what I found is that if you are a Parkinson's doctor and specialist like myself, where you deal with a lot of patients, is that everybody's so different. It's really wonderful to have an option for advanced Parkinson's. We do a lot of DBS for one of the busiest programs on the West Coast, and I think it's a wonderful therapy. Duopa is an excellent therapy as well, and so now we have an additional treatment option for patients with advanced Parkinson's.
Yeah, to have choice actually at that point, when usually people feel like they have no choice. That's actually really nice. Now, are there people that who you can have both, right? You could have DBS and Duopa.
That's correct. You can have DBS and Duopa. We have 2 patients that have gone through and have DBS and Duopa, and those would be on a case-by-case basis. I certainly wouldn't encourage anyone to seek out both at the same time. That would not be the intention. For anybody with medicine whose the medicine is kicking in and wearing off, or has disabling dyskinesia, but responds to medication, DBS is a really great therapy. And really the criteria are very similar for Duopa. The medication, you want your levodopa to still work because you're going to be delivering levodopa continuously. It may not be that you completely return to normal, but if levodopa helps you in a meaningful way while it lasts, even if it's just a few hours, either treatment may be an option. Okay. One thing that I've noticed about the Duopa treatment, and it's not really been tested extensively in this group, is folks with more advanced Parkinson's disease who may have problems with walking. Let's say the medicine helps them quite a lot, but they still have a lot of problems with walking. But otherwise, the medicine's kicking in and wearing off. The DBS may be considered more risky, sometimes worsening gait for those patients. And I've chosen Duopa and recommended it for many of my patients for that reason. And also, if there's impairment of thinking ability, the mind is impaired, then use of Duopa would probably be much preferred, because DBS deep brain stimulation can worsen the mind, whereas Duopa typically would not. You can take too much levodopa orally or through the Duopa pump, so it's not that you're off the hook for that risk for confusion or hallucinations with Duopa treatment, but the risk of irreversible damage to thinking abilities and memory and cognition is much less with Duopa, I would think. But it hasn't been tested thoroughly in those advanced patients. But I have had many patients go through that. Probably most of my patients really aren't DBS candidates and a little more advanced, and they do quite well. But you could do Duopa early on or more advanced, and there's really early on being the medicine's kicking in and wearing off when that starts to be a problem, or with more advanced Parkinson's where there may be contraindications for DBS. And that's just something that the patient and their doctor should discuss on an individual basis as to if it's appropriate.
Okay. You know, I've had people ask me, they hear the word motor fluctuations, and of course there's not really a clear definition of what advanced Parkinson's means per se, except for maybe it means motor fluctuations. Do you have any thoughts that you can share about what does advanced Parkinson's mean? I mean, how do you know? It's such a long, slow disease sometimes. How do you know what that means and when it might be about it?
Yeah, so the advanced, I would say moderate Parkinson's disease to me, and I have more of a definition that I think applies for patients and more as it pertains to their daily activities. And that's really what most people care about. It's what they can do or what they can't do.
Yep.
So when your daily activities are interrupted because of the motor kicking in and wearing off, the tremor, slowness, stiffness, slower walking, and when the meds wear off and you cannot no longer do those things well or without much difficulty, and you have to work harder to get things done when your meds wear off, but then the meds kick in and you do very well. I think that's a very good, solid definition of moderate Parkinson's.
Okay.
And advanced Parkinson's is more so, in my mind, that when your meds are wearing off, other people have to do things for you. And that's really different than some of the other scales. We have good research scales and scales we use clinically that govern more one side of the body versus the other, versus walking ability. And it doesn't always take into account the more complex aspects of Parkinson's, but like thinking ability that sometimes can get worse if medicines wear off, or sleepiness sometimes when medicines kick in. There can be all sorts of problems, and it's so individual, but everyone has to function.
Right.
Everyone has to live the kind of life that they were living to some degree, and that's what we're trying to restore with medicine. So I really find it best to talk to a patient about, what is it that you really need to do or want to do that you can't because of your meds wearing off.
Mm-hmm.
And if, you can still struggle through that when your meds are off without assistance, that's certainly moderate. More advanced, you're really requiring help or supervision, or really requiring other assistance in some significant way. But bottom line, it really just matters how you're able to relay that to your doctor and how well you can get the medicines to cover the wearing off and the progression of Parkinson's.
Okay, that's actually probably the best definition and explanation, and it's so practical because it's real life, everyday life.
Well, Parkinson's is so complicated, I try to make it simple whenever possible.
Yeah, that's for sure. It is one complicated disease. Now, you talked about, that was interesting that you talked about how it's a similar dose. It might be the same dose that you've always been taking. It's just that so my image of it is that it's just sort of spread throughout the day as opposed to like a lump sum that then wears off through. It's like just spread like more of an even dose almost. Well,
yeah, I mean, really, yeah, the way that a person takes oral anti-Parkinson's medicine, and particularly here we're talking about carbidopa, levodopa, immediate or extended release, or Rytari, or Stalevo, or combinations like that where there's levodopa. A person takes the levodopa and then there's a burst, kind of a pulse, a flash of medication. And levodopa kicks in typically very quickly after it's taken into the stomach, and it passes through the stomach. So drinking water with it, taking it on an empty stomach is key to getting a good response to oral medicine, but usually 15, 20 minutes or so for most patients. So that's key. and then if the stomach holds on to the medicine, sometimes it can come out later on, and that can trigger a lot of dyskinesia, involuntary movements, and overstimulation effect. But the oral meds, you're limited to a pulse type activity. With CR levodopa, that's not as dramatic. And maybe longer lasting, but the CR, or the extended release formulations of levodopa and Stalevo, tend to be erratic and often hard to predict the response for an individual patient. For earlier or moderate patients, it's less of a problem, but as Parkinson's becomes more fragile and brittle, the response to extended release formulations is harder to fine tune and micromanage. And in Parkinson's, any Parkinson's patient who sees a specialist knows that their doctor really likes to try and micromanage and predict things. The Duopa pump is really doing the same oral medication type chemical, the same chemicals used, but it's a continuous delivery. It's not the same as an IV, but if you could imagine how much more smooth an IV infusion might be, it's kind of an intermediate between an oral pill and an IV infusion. It still has to be absorbed into the bowel and make its way to the brain and enter the brain before being effective. But the stomach is a very big barrier. Medicine non-compliance, or even just having good compliance, but simply having to take a medicine every 2 hours is very, very hard to do that. Right. And we have some patients who are amazingly good at it, live their life around taking their medicines. Right. And this really frees them up. So in exchange, if you think about, if a person has to trade off something, you may have a small tube coming out of the stomach, but the trade-off is that you are no longer tethered to the frequent medicine dosing with its consequences if you make an error. Or simply the medicine's not working as well. So you do get quite a lot out of the modifications of the tube and the changes in your body. That's nothing to take lightly, but there's a pretty massive trade-off, and it's very often extremely beneficial for patients.
Sure. Oh, taking those meds, the schedule, the time it takes to actually be attentive to the schedule is just mind-blowing for some people when I talk to some people.
Some of my patients, I just can't imagine, having to live life, or what, kind of life, quality of life you have if you're so reliant on having to take the medicines this frequently. It's a horrible situation to be in. And all we can hope is that they progress slowly to that point. And fortunately, Parkinson's is slowly progressive for most patients. But, when it gets to that situation, it's a real problem for patients and their caregivers. Also, it's a pretty big burden for caregivers, and also even in nursing homes. I think we all have heard many stories of, nursing homes are very often understaffed, and they do the best they can. And, I think really care about their patients, but just getting that medicine there within, a 10, 15-minute window, it's tough. And so we've had a number of nursing home and it really takes the burden off of the staff having to worry about the exact timing. Another thing that's really unique about the Duopa pump is the ability to give the extra dose of medication. There's a button that allows you to give an extra levodopa dose, and that's set by the doctor based on their determination of what the patient needs. But with regular Parkinson's medicine, you can only go in increments of 50. So 50 or 100, 150, it's hard to change from that. With Duopa, you can get down to very small, several 10 milligram doses, 20 milligram doses, things like that. With the Duopa pump, and being able to give just a fine little burst of medicine, let's say after meals. Many people struggle, or if they're maybe in a more stressful situation, they maybe wear off more. If they can kind of predict that, being able to just hit the button on the pump and deliver an extra dose that goes in within minutes, exactly where it needs to go and absorbed, is really a very powerful thing in it. And what I like about it is it puts more control in the hands of the patients. And in a situation like Parkinson's, where people have so much lost control over their bodies in many ways, anything that we can do to give them more control is a tremendous benefit.
Mm-hmm. Again, for quality of life. Oops, I'm echoing. I'm curious about going into that part of the intestine. Does that actually help nausea?
Well, I don't think it would help nausea. The nausea that it comes with Parkinson's treatment is largely due to levodopa.
Okay.
There's a special ratio of formulation of carbidopa to levodopa. And in fact, carbidopa with levodopa given together, we call Cinemet, which I have a degree in Latin, actually, more so than science in my background. But my only use of Latin for the day is explaining this, that Cinemet is kind of the Latin version of without nausea.
Oh.
So carbidopa is intended to prevent nausea. I don't really think that the Duopa pump would really directly get around that, other than it might level off rather than having a big burst of levodopa, it could smooth that out so that it would be less severe. But there are different methods to treat levodopa-induced nausea in Parkinson's disease. And some patients will have nausea for another reason, but giving extra carbidopa can be done. There's other medications that are available that may help that. But standard anti-nausea medicines like compazine, Phenerin, Reglan, those medicines are not advised in Parkinson's.
Mm-hmm. Okay. And then once somebody has a pump put in, there's a titration period or a titration that happens. And can you just describe a little bit about how that works? It's not like you just all of a sudden get it put in and you're done.
That's right. There is a little bit of front-loaded work there. With the one thing to realize is that doctors and clinics and hospital systems will all do this differently. There's different ways that hospital systems are set up in clinics. So I would really, before going into too much detail, I'd just say, seek out a Parkinson's specialist that has done a number of these or has the interest at least in getting these programs started, and they will work with you to find the thing that's best for you. Okay. Now, I'll say that in our clinic, we're a private practice. We're very patient-focused. We accommodate quite a lot to patients' needs. And we have a system worked out very well. We do it quite a bit differently than the way it's initially done with the AbbVie equipment. We have our own tubing system that we use, which is very, very old tubing system, very simplistic. And we have an extremely low rate of pain around the procedure. We use an extremely low dose of sedation and pain medicine. So even patients with lots of problems with anesthesia, right, when we do the procedure, they've been able to do very, very well. We have our tubes inserted on one day, then the next day we bring a patient back into clinic and start them on Duopa. And we have a calculation that we use based on the prior Parkinson's medicine, and we simply put the number, the milligram doses of levodopa into this equation with the amount taken in the morning, and then determine what the pump needs to be set on. And we're often very, very close with this prediction. Some adjustments usually determined, and we test the extra dose to make sure a patient does well with that. And then we sort of, we do no more than three days at a time typically. We have a lot of patients coming from 6-7 hours away or more to our clinic. So based on travel time, the logistics are a pretty big deal. Family usually needs to be involved, or a caregiver. So it requires a bit of a investment in having someone else help a person if they're pretty fragile with Parkinson's. Right. So we do ask that of them, and then otherwise the follow-ups would be quarterly follow-ups, regular clinic visits, to adjustments, and we can even set the pump up if a person's coming from very far away. Can set the pump up so that a caregiver who is comfortable with this could make some adjustments on the pump themselves based on how the patient is doing under the doctor's guidance. Okay. So it really is very, based on the patient's situation and how much support they can get, right, and the clinic situation too. So it varies quite a lot. But that's been our experience, and we've really done well with that.
Okay, so it's really flexible. Is there anything that you think, I know we're getting close on time here, is there anything that you would recommend a person considering this or wondering if this is good for them? Is there anything in particular they should ask their doctor or talk with their doctor about that they might not think to?
Well, I think that just educating a person who's interested in Duopa, who maybe isn't interested in DBS, or is still having fluctuations with their meds kicking in and wearing off, would be a candidate for this, so long as their meds are working and giving them meaningful benefit. There's been a bit of hesitancy, I think, to adopt this because for a neurologist dealing with stomach tubing and other things, it's quite a bit to deal with. But if you are interested, say that again.
Different part of the body. It's not the brain.
Yes, it is. So we put in quite a bit of work in our clinic to bring this to our patients. But, to let your doctor know how much it would mean to you to have this option. The neurologists out there are really very dedicated. We're very dedicated, especially to patients. And I don't think I've ever met a neurologist who really doesn't want to go the extra effort to help their patients. But if a patient's really interested, and let the doc know that they're willing to troubleshoot this new type of treatment with them, and really kind of be involved in getting a few of these programs going. It probably would take some of the hesitancy off the neurologist to do this, but it is a very new treatment that, considering what we do with deep brain stimulation, other types of things, the insertion of a tube into the stomach and hooking it up to an external pump, it's really a very, very simple therapy, and much easier to get started than I've thought. So I would just say that if you have advanced Parkinson's, waiting and having further physical decline, just waiting and waiting and waiting for cures and other advanced treatments, it's certainly, we all are very much hoping and praying for those things to happen. But you really can't afford to wait too long if you're declining, you're at the point where you're changing your life and doing less because of advanced Parkinson's, and don't have a plan in place. You really should consider a therapy like Duopa or the other advanced therapies that we've mentioned, because it can make such a wonderful difference.
Oh, this has been so helpful. So much information. Thank you. I'm going to put your website on the video here at the end of the video so that people know where they can link to it, because you have some really great kind of before and after videos too that just allow people to see what that experience is.
You bet. Definitely take a look at those videos. We're at www.nw, the number 4N, me.com, nwin4me.com.
Okay.
And certainly encourage patients there. And, if other docs have interest, I'd be happy to talk with them to let them know how our program got started, or, we see patients from all over as well. So if that's needed, but yeah, definitely it's a wonderful treatment. And I think that your patients there and in other areas will be more and more involved in receiving benefits of this, and hopefully other exciting things in the future.
Right. Oh, thank you so much for your time. I can't tell you how much we appreciate you taking time to talk with us today.
You bet. Thanks a lot.
Thanks.